Good evening. Welcome all to the 10th Lloyd Cox Memorial Lecture. Tonight's event is jointly hosted by the Robinson Research Institute and the Lloyd Cox Foundation. My name is Professor David McIntyre. I'm a Professor of Reproductive Systems Medicine and the Director of the Robinson Research Institute. And I'd like to start by acknowledging that we are meeting this evening on the traditional land of the Kaurna people and that we respect their spiritual relationship with their country. We also acknowledge that the Kaurna people as the traditional custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. I have some distinguished guests that I would like to acknowledge as well. We have the Honourable Grace Portalesi, former Minister of Education and Child Development, here with us tonight. We have our Chancellor, the Honourable Catherine Branson, ACSC. We are also joined by David Cox, the son of Professor Lloyd Cox, the namesake of this lecture. We have welcome to the University Council members who are here tonight, University of Adelaide staff, students, alumni, and of course the rest of you all here tonight. Thank you so much for coming. So I have a couple of quick housekeeping items to mention. If there is an emergency, please walk back up the stairs, out the front door, follow the exit signs, into North Terrace and head up the hill towards the Samri. Why they got you walking uphill in an emergency, I don't know, but that's the instructions I've been given to pass on. If you would like to use the bathroom, I'm sure you've already know where that is, but it's just to the right here, out towards the front bean bar near that cafe there, if necessary. So the Lloyd Cox Lecture, for those of you who don't know, has been running for 10 years now, as I've mentioned. It brings some of the most inspiring researchers from around the globe here to Adelaide to talk to you all about thought-provoking topics. In 1958, Lloyd Cox was appointed as the Foundation Professor at the University of Adelaide's Obstetric and Gynecology Department, which at the time was established in the Queen Elizabeth Hospital in Adelaide. He had previously worked in New Zealand and in the UK, and his vision when he came to Adelaide was that the Department of O&G would be a world leader in women's health research. He also wanted it to be science-based. And to achieve this, he strongly felt that scientists and clinicians must work together. And he put that belief into practice. Under his leadership, he appointed Ron Cox as a biochemist. This was the first department of its kind to appoint a scientist in a role like this. Hard to believe, I know. He also encouraged people to look at new techniques, new methods, as their research required. And that led to several world firsts and Australian firsts under his leadership, including the establishment of the first sperm and donor bank program here in Australia, the first successful birth following ICSI, and also Australia's first birth following pre-implantation genetic testing. Professor Cox retired in 1984 and was replaced by Geoffrey Robinson, who is of course the namesake of our institute. But the culture that he created of collaboration between scientists and clinicians has remained a key facet of the research that we do. We have now more than 40 research groups made up of scientists and clinicians, collaborating across the themes of fertility and conception, pregnancy and birth, early origins of health, and child and adolescent health. And our focus remains on undertaking world-leading research that helps babies and children and their families get off to the best start in life. Now, to achieve this, we have to aim at all times to be undertaking impactful research that ultimately has to be translated into meaningful knowledge that can actually be acted upon and transitioned into often a clinical setting. But that transition from bench to bedside is a very, very tricky one to navigate. It involves close engagement with public and industry partners. There's often ethical considerations to account for. We're often fronted with issues around economic implications, education, and of course it involves a lot of implementation and policy enactment. We're very fortunate that our guest tonight is an expert in all of these areas and has navigated to perfection that type of pipeline to translation. Professor Helena Teede, AM, is a clinical academic and reproductive endocrinologist at Monash University here in Australia. She holds an L3 and HMRC Investigative Fellowship in Women's Health. She's the director of the Monash Centre for Health Research and Implementation, and there she's also the lead on the Centre for Research Excellence for Women's Health in Reproductive Life. Her career is nothing really short of stellar. She's had more than 700 published articles, tens of millions of research funding, and she's the incoming president of the International Society of Endocrinology. She's also on the Council of the Australian Academy of Health and Medical Sciences and chairs a World Health Organization task force. Somehow she finds time to run a very large research group amongst all of these other activities she's partaking in, and leads international guidelines and translation programs on a wide variety of topics relevant to women's health, including polycystic ovary syndrome, infertility, menopause, and healthy pregnancy, and has had a genuine impact on policy and practice here in Australia and elsewhere. So we're very privileged to hear from Professor Teede today as she presents on research with impact, translating women's health research into practice and policy. Please join me in welcoming her.
Great.
You can now
Thank you.
wander around.
It's always challenging standing up when someone's done an introduction like that, isn't it? Thanks. Great to see so many familiar faces in the audience too, and thanks very much, David, for the introduction. All right, yes. So I did the really silly thing on the way over here in the plane today of deciding, when I read a little bit about Lloyd Cox, that I was going to change my presentation. So we'll hopefully hit the mark. So I'm going to talk about research with impact and around meeting community needs, driving innovation for improvement and learning and improving health outcomes. And I think given the history of what I've been able to establish about what Lloyd Cox did, it probably sits reasonably well. So I'm just going to acknowledge the acknowledgement of country that's already been given today. And my disclosures are that I am a non-paid advisory board member for Roche because this has a specific impact, as well as pretty much all competitive government funding for most of my research. So Lloyd Cox came to Adelaide for a quiet life, apparently, and then did some amazing things after he arrived in terms of abortion, maternal mortality, perinatal death. But there were some fantastic examples in what I was able to find about how he drove difference in policy, difference in practice, which is, of course, really important and also a great privilege of what we get to do. I'm going to indulge just a little bit here. So I did my undergraduate training about the time that Lloyd Cox retired, I think. So I went into medicine at Monash University and trained as an undergrad, which was 6 years back then. I then went into physician training around 1990, which takes a little while, and then started my PhD in 1997, which was actually in menopause, not in the area I'm working in now, and was largely in animal studies, benchtop research and clinical trials. I then went on to have my family in 1999 and 2001. I'll speak briefly about that. And at the time, there was not a single female clinician academic who could be a role model, except for Priscilla Kincaid-Smith. And I don't know how many of you know Priscilla or of Priscilla, but she was the president of the International Academy of Medicine. So she was like here. So it was a bit hard for her to be my role model. So in fact, my mentors actually were all male. And they have all initially, and they were all fantastic because they were the ones who were doing what I wanted to do. But I must say the difference is back then that when I had my family, my husband is a clinician academic as well, and we very much have co-parented our children. But it was very, very challenging at the time. The system is still not, but definitely was not set up for this. So it was a bit of a challenge navigating what that looked like. But I had fantastic mentors to help me through. I then went on to my NHMRC career, well, my research career, and I'm very fortunate and probably more a product of what used to be, but I have had an NHMRC fellowship for every single year since I graduated from my PhD, and that doesn't happen anymore. It's just not the system, and I won't take responsibility for it, but I was on NHMRC Council when the system did change. And what they are now looking to fund is not people who do research, but people who lead. It's all about whether they're actually leading research that will have impact. So I've been very fortunate in that career trajectory and managed to juggle it with a family, and that's largely been because of my mentors. But this big blue arrow that you see here was what changed absolutely everything I was doing in my career, because I had my head down, I had my backside up, I was a clinician, I was busy, we're all really busy. And I was doing my research, which I thought was really important, but I wasn't being strategic. I wasn't lifting my head up out of the sand. I wasn't really seeing what I was trying to achieve. And therefore I was just like everybody else in my hamster wheel, complaining about lack of funding, complaining about lack of collaboration, complaining about lots of things potentially, but not really being strategic and seeing the wood for the trees. Now, that I didn't put my hand up for that exec MBA. I had had enough post-secondary school education. But I'm not very good at saying no, or I wasn't previously, and when the CEO tapped me on the shoulder, I said yes. It was by far and away the most spectacular and useful education I've had. And I'm not saying anyone should do an exec MBA, but I do think all of us, if we want to make a difference with our research, need some insight into leadership. Because there is almost nothing in an undergraduate health professional education or research training about what leadership is and how to do it. So the people who do it tend to be innately good at it, but they are really important to have around because they will make a very big difference in terms of the direction that you and others who work with you go to. I then was offered a clinical leadership position, and I was fairly early in my career and tried to say no back then, but I just kept putting up more barriers for what I would need to do it, and eventually they said yes, so I took the role. I will share with you at the time, I was just coming into a level D, and it was a level E position. So I said, well, hang on a minute, I'm not at a level E yet. It was more EFT than I currently had. And there were a few other things. It was a 5-year contract. And I went, no, I don't think I can do it. I had terrible imposter syndrome. I said, I'll take it at a level D at a lower salary level for 1 year because I might not be good enough. And if I haven't heard that story from so many people who are early in their career, especially young women, I spent a lot of time picking that up. But fortunately, the chair of the then board on the not-for-profit, who's an engineer, sat me down and said, what is your problem? We know you could do this job. You've been here for 5 years. We want you to do it. We've offered you the money. You have to do it at a level E because that's what it is. I would never have this discussion with you if you were not a bloke. If you were a bloke, beg your pardon. And I went, oh, I've fallen for something very typical here. And so I double-checked myself, and that was entirely me, and took the role and probably haven't looked back since. So that clinical leadership position was important because I was the only head of a unit in my field in the country. And that remained, female head of unit, that remained the case for a good 11 years after that. When someone else came in, I was then able to step back. I then, in about 2010, had what I call my crisis of relevance. So I was doing this research. I was getting published in reasonably good journals. You heard I had a few publications along the way. They were mostly Q1, and I was getting research grants, but I really wasn't convinced I was making much of a difference. I went to a conference, even in the Endocrine Society, and I spoke to a reasonably large audience, and everyone said, that's lovely research, and people cited my papers. But unless I was seeing the people in clinic or the people I was working with seeing people in clinic, it wasn't changing much. So I almost gave up research. But fortunately, again, I had really, really good mentors who said, if you don't like it, fix it, which was spectacular, including using that leadership knowledge and experience, which was invaluable. So basically flipped everything to be far more strategic, much more about what the research was that we were doing, what the translation programs were. I also took a lot more roles I would never, ever, ever have taken. Like I put my hand up as the president of the Endocrine Society. I was the first female clinician president. I've been president of other things, all because I had a purpose, not because I wanted the position per se. I've almost put my hand up for other things and then run it by my mentors and decided not to. I've been on 3 NHMRC principal committees, done a lot of work with policymakers. Your policymakers, 85% of their time is spent with mining, tobacco, big food, gambling. Every single one of you in this room has something more important to say than they do. So one of the things I learned in one of my subsequent leadership programs is that I should spend a lot more time with government, and I did. And it's actually really important. And now I do work with WHO, which is really politically challenging, but very potentially impactful. And along the way, Rob Norman, who's in the audience tonight, was one of the key mentors that I had. Not only a mentor, but actually a sponsor. For many of the people who are early in their career in the audience, the number 1, number 2, and number 3 factor that is related to your success in your career is mentors and networks. And yet if you ask many people who are early in their career, do they have a mentor, they'll tell you, oh, it's so-and-so, because they go and meet with them occasionally, they look up to them, which is not a mentor. A mentor is a formal relationship, and so many of us don't have that, and it is really, really important. So if you don't listen to a single other thing I say tonight, if you are early career, get yourself a mentor. It's really important. So then along came these two lovely, gorgeous things. That's my husband in the middle there, who's co-parented with me. There's no secret about this, but this is my youngest. I should have been able to diagnose her ADHD when she was 2, when she couldn't decide if she was Shrek or a fairy princess at the same time. She's highly functional, very intelligent, but classic young woman with ADHD, so didn't get diagnosed for quite some time. But when these two came along and I had my academic career and my clinical career and no role models who were doing what I wanted to do, it was like that. And to some extent it is still like that. Don't regret it for a second. Still the best and most important thing I personally think I've done in my life. But part of my goals in my career was to try and make this much, much easier. So in terms of research, so forgive me for indulging a little bit about that career trajectory, but it perhaps was atypical in some ways. This was, in fact, the Victorian research continuum diagram until very recently, and it's still all around the world is. And the idea is that if you've got people in a lab, somehow, people in that lab end are supposed to know exactly what the most important problems are. And they're supposed to be able to come up with fantastic discoveries, which automatically, seamlessly go through from bench to bedside to practice. And yet we know the drop-off there is about 98%. In fact, in Australia, it's more spectacular than that. We are actually quite appallingly poor at translating our great discoveries into practice, which is one of the reasons that discovery research is struggling to be funded. So if we want to fix that, we need to do some of what David said and be much more clever about how we're making sure someone at this end is not responsible for getting it to the bedside, but they are responsible for getting it part way along that journey. Where is your next step? How are you working with people who are next? How are you making sure that what you do is important? I remember I had a wonderful conversation with a really prominent academic, older in his career, and we were talking about reproductive health, and so many of them had said, how do we get more funding? And it's a classic, don't ever go to a politician and start with, we need more funding. May as well shoot yourself in the foot. Actually start with, we've got this really big problem, we've got this really good collaboration, this is the difference we can make to our community. And believe me, reproductive health is not hard to make that argument. So one of the things about this was he said, well, look, I said, so if you want to do benchtop research, these are the really critical, biggest problems that are facing reproductive health. Rapidly rising BMI, advancing age, all of the problems that are really critical. And his response was, well, I don't really care because I just want to do really good science. And I said, well, that's wonderful, but you're going to have to go and find someone to fund you. So one of the things about this is science is really important. I'm not underestimating blue sky science at all, but just make sure you're looking at working in areas that are strategically important, that you can make the relevant argument that they are important for health, because ultimately we're all funded largely by government, or some of us by industry. So how do you make that argument that you're working in an area that's really relevant? And then how do you make sure that the key end users are on your journey? That doesn't mean tokenistic patient and public or consumer and community involvement panel for your early discovery blue sky research. Please don't do that. The panel can see it a mile away. That means that you work in an area where you have evidence of relevance, where you have the appropriate level of consumer involvement, and that would be another talk, but it is really important. How do you justify the work that you're doing? How do you work spirally? In fact, I've got another slide with a piece of spaghetti. And it doesn't look like this at all. The really successful scientific discoveries look like a piece of spaghetti. It's a bit like policy making. So how do you make sure that you have your artificial intelligence data scientists right smack bang in the middle of your lab and your biobank that's generating all this great data? How do you make sure that your clinician researchers are absolutely collecting all of the data that they can for you to use their samples and biobanking? How do you make sure that people are not in their silos? Because currently they absolutely are. And believe me, if we think there are some challenges with discovery research, our clinical trialists have a lot more to answer for. And this is publicly available data, but we spend about $600 million a year on clinical trials in Australia. Half of those trials never publish a single paper, including a protocol paper. Now, that's not because we don't have good researchers. It's a bit like that elsewhere, but it's not like that in the UK, it's not like that in Canada. It's because we make it so competitive and unrealistic to actually get funded for a grant that by the time you get it to that point, you can't deliver it. and recruitment is incredibly difficult. So how do we make sure we are all working much more closely together? How are clinicians embedded in practice, making sure that their clinical trials are relevant, and how are they working across that whole spectrum? How are we creating registries to embed clinical trials so they're efficient and much more able to do, so that the system ends up with research that is going to be pulled into practice and doesn't have to be pushed into practice. And we don't have this, but we can act and function differently. And in places like Adelaide, we're all pretty close and actually hopefully can all really collaborate. This should be much easier than perhaps it is elsewhere. So one of the problems is implementation and translation. The classic story about once you've developed a beta blocker and you've shown that that beta blocker improves outcomes after acute myocardial infarction, people are in hospital when they have their myocardial infarction. They're in coronary care. Surely it should not be difficult to get that into practice. It's published in New England. It's gospel. 17 years after it was published. Because everyone just thought, I do my publication, I walk away, it's someone else's job to translate. It's a bit like I develop my molecule, it's someone else's job to translate. So we're not thinking about how to get that across the continuum. And very slow to the table, Australia's realised we need much more focus on implementation and translation. And I've got a couple of positions in the UK and I've learned a lot working over there, and they are much, much more advanced than us. They've also done a lot of things wrong and learnt from them, which we can learn as second starter advantages on this journey. But biggest problem is this, no matter even if we paint them beautifully, we're all stuck in silos. And it's often quite lonely walking up here and quite dangerous. So we have to make this much more normal practice. It doesn't matter whether you're a clinical trialist, and if I had $1 for every time a discovery researcher has come to me and said, we want you to be a collaborator, we're putting a grant in tomorrow, we need you on our grant and we just need your samples, which is not collaboration. And clinical researchers who could be collecting absolutely invaluable specimens are really contributing to important discovery research are not even thinking outside that square. So getting outside those silos in terms of the research continuum, but also in terms of the expertise that you bring to the table. I was speaking to some of your ECRs earlier this afternoon, and one of the things I said, they were all talking, well, a few of them were talking about the niche area they were going to work in, you know, PCOS or infertility, or they were going to find their niche. And I actually said the niche is not really the issue. Find the cracks. Where the cracks between the niche. There's a physics graduate who's in the middle of a biology group here. Spectacular. He's going to fill a crack. The team member that's probably most useful in my team, about 120 at the moment, has a physics, data science, coding and philosophy degree. Very unusual chap. He can write. But he sits in the middle of our largely clinical applied research group. He goes away and quietly writes code, puts it on GitHub and comes back next week to do something inspirational that we would have taken 9 months to do. It's the people in the cracks. It's working with people who are outside your silo. It's always trying to do that. And when we go around the world and we go to conferences, we just try and meet people who are in our silo. Great. But it's not going to challenge your thinking. It's not going to make a difference. Setting up alliances, your Chancellor has come from a law background, I believe. Some of the really important work we wanted to do lately, we needed policy and regulatory change. We went to the lawyers and said, we really need to do some research with you. Unbelievable impact, because we couldn't do that and we really needed that. So yet, I mean, how many people in the room would think about going and working with someone from a completely different faculty? So universities are spectacular. So I showed this slide to the Vice-Chancellors from the universities around Australia not long ago. With a slightly more challenging question, and it was interesting to see the reaction. The other problem is we see the world from our understandoscope, and the more expert and the more influential you are, the more narrow your understandoscope. It's like an expert. You become, you become, more and more about less and less until you know everything about nothing. But the problem is you just see the problem from your perspective. So I'm a clinician. I've seen thousands of women with PCOS. I've seen thousands of women with diabetes and with challenges in pregnancy. But I don't necessarily have that lived experience perspective. I don't necessarily see what it's like for a rural GP or a community diabetes nurse educator or a community health worker in an Indigenous context, or a basic scientist working in the area. So if we keep seeing things through our understandoscope, we will never see the big picture problem. And it's really important that we do that. And also it doesn't take a lot of time. The other problem we have is that most of us are like this. And the more we get really specialised in our area, the further down our rabbit hole we get. And if you really try hard, you can sometimes get people to turn around and stick their head up. But what we actually need is that. So how do we get to that? And a lot of that is going to be about getting people to think differently and make sure that they're thinking about who it is that they can work with who can solve that problem for them. So we all work in this system. Our hospitals, the CEOs, have episodes of care, waiting time, patient flows, metrics. There is not a single metric about improvement. And until 2 years ago, there was not a single metric about research. So it was not the job of any hospital CEO. In fact, we just took money and time and we would just risk. If you look at the ethics committees, we would just risk to a hospital. And I'm quite surprised they actually allowed us to continue to do it, really. Now, 2 years ago, that changed, and you don't get your hospital accredited now unless you're accredited for research. All of a sudden, it is a CEO's job to do research and to enable research and to support research. So they're sitting there going, how do I do that? Can you help? So it's really important as a time to go in and talk about how you can actually help them do that. Very soon, improvement metrics are coming, and they're going to be sitting there going, how can I help? Our universities are funded based on student enrolment and high degree completions. They're not funded on impact. In the UK, 25% of the funding for the higher education system and research system comes from impact. Boy, it's not, ERA is challenging, it's not perfect, but boy, is the discussion different. The focus is different. The people who are funded are different. Everybody can start to tell their impact story. That is coming, and it's coming fairly soon. Any of you who are not sure of that can read the Higher Education and Research report that was tabled by Parliament earlier this year. Again, our researchers were about bibliometrics, grants. What got me those fellowships for many, many, many years was the number of publications or the amount of funding. Now, as I continue to be on all those wonderful review panels, it is your leadership in research, it is your impact, it's your top 10 publications. It's not your 700. And how do you start to tell that story about your impact? So we need to flip out of that. So you're starting to see changes in the system that are going to make us behave and function in a way that's actually going to have impact. So in my career, I've done a few things that are really about how you start to drive impact at a systems level and start to address these. So the first was this. So the Monash Centre of Health Research and Implementation, there were 2 of us who started about 15 years ago. There's about 130 of us now. And that's been a very big journey, but it's really been about, we do anything from some discovery research, but mostly clinical and through to implementation research. And we tend to do women's health, both in the bikini line, classically, and also outside. And you heard a little bit about what we do. A lot of what we focus on these days is how we have implementation and how we drive change. And this is relevant to people at all levels of research. One of the things about the main frameworks for implementation is you take an evidence-based intervention, which comes from some of the fantastic research that you've all been doing. How do you actually get it into policy or get it into practice or get it into lab or get it into industry? And often what we do is we focus down on individual relationships and working with individuals, usually in our own silos. We don't think about, okay, we need to get individuals on board, but it won't stay. It'll only stick while the champion is there, unless we think about the organisations we work in and whether they change culture and actually allow us to innovate and make a difference, and then the policy and construct setting. I'll give you some examples of this in which we work. So if we want to drive an evidence-based intervention into practice, no matter sort of depending on where you are on that research continuum, how are you engaging with each one of these levels of the system to make sure that you're able to translate your work? And then there has to be a process to do that, and most people falter at the process. So lacking a really good process on how to drive evidence into practice, we did what we usually do, which is undertook research to find out how to do this. And I won't go into this in great detail, except to say that one of the things from my leadership program was, I'm never going to be the world's best scientist. I'm probably never going to get published in Nature. And that's okay, I'm quite comfortable with that. But one thing that was in my toolbox, which was my strength, is I can herd screaming cats into a burning barn. In other words, I can get people together when they are navigating those silos, and so that's something I have pretty shamelessly leveraged. And one of the things about that is consensus processes. And there are a lot of really good social sciences approaches to getting people to consensus. Starting off with what all the key questions are about how we're going to drive improvement, getting everybody to do pre-ranking, getting consolidations in workshops. These are actually all methodologically robust and written up. And you end up with a consensus. In this particular case, it was a consensus on how we were going to drive improvement nationally. Now, this is 4 years of work and now has $58 million invested in it. But essentially, learning health systems are increasingly prominent around the world. Most of them are led by researchers and they're not learning health systems at all. They're just learning academic systems. But the learning health system was generated from all of the most successful evidence of any improvement driven by research in clinical practice, in cystic fibrosis, in stroke, anything, anywhere in the world. We did the systematic reviews, we interviewed all the people who were innovating and actually with a demonstrated improvement in healthcare. And they came from all different parts of that research continuum. It wasn't the type of research they were doing, it was the leadership they were demonstrating. And the biggest, most important thing they did was they did not start with a solution. They didn't start by saying, I've got a digital gizmo that is going to solve this problem and I'm just going to implement it. Because the problem is often that doesn't solve the problem. So the ones that really made a difference were the ones that understood the problem they were going to solve. They understood that problem by going out to stakeholders and working with them and understanding what the problem is they were addressing and why. Hence that discussion about the most critical issues for reproductive health at the moment, and there's some data coming out about this shortly, is advancing maternal age and rising BMI and a lack of recognition of risk that actually brings with it. So those women are still in Australian context treated as low risk. Turns out being a low-risk pregnancy is the most risky thing you can possibly do right now, with about a 2-fold increase in neonatal death. So we need to recognise that there are some really, really massive population level changes that are going to need really good research right from the why at the discovery end through to the public health. So one of the critical things is work out what you're working on and why it's a priority and who you need in the room. Then what is the evidence from practice? We all know this, but I got 200 people who were the leads and the key people in Victoria in quality and safety. 200 EFT. It's a lot of funded people. I put them in the room and I got Helen Bevan out, who was from the NHS Academy, who's really popular with people in innovation. And I did a little bit of a talk first and I asked them how many people in this room, so these ones paid to drive improvement in our healthcare, use research to guide their improvement. How many people said this? One. Because she had done a PhD and she said it was almost impossible because no one else would listen to her. So we have a dramatically huge chasm between all the fantastic work you do and what's driving practice. And yet we have all these clinician academics who are seriously not at the table. So our research in Australia, as opposed to other countries, shows that our clinicians think it is our researchers' job to drive improvement. Our researchers think it's their job to do research. So it doesn't seem to be anyone's job to drive improvement. And that's going to have to change. And if you are strategic and you are leading and you are making a difference with your research, you will stand out quite significantly. The other thing is once you know what the problems are and what the best practice is, and many of you are feeding into that best practice, what are we actually doing? Because often when we know what best practice is, it is not what we are doing. And we're not measuring the things that are most important to our patients. So how do we make sure we can actually look at, and registries are a classic example, how can we make sure we're looking at what is important and actually using our research in practice? And then how do we drive improvement and change? So 4 simple things. What is the problem? How are we using evidence from research? And how do you make sure your evidence from research is getting into practice? What are we actually doing in practice? And if you can show your evidence is not getting into practice, that's going to be a really important gap we need to address. And then how do you drive improvement? And yet all these are silos. Almost all the social scientists and consumer groups and others who talk to patients effectively don't manage to translate that up or anywhere that matters. Almost all the people who do guidelines just do guidelines and are not responsible for translation. A lot of people who do research feed in here but don't actually see themselves as feeding into a system. So it's when you start to put it all together that matters. So in this centre that I have, and I'm not going to go into the detail, but there's 3 main parts. We have a whole series of research programs and these just keep getting added on as things happen. And I'll give a couple of examples of this. But one of the main things we do is whilst you might have an animal house or a confocal microscope or a synchrotron in a lot of the discovery research, in applied and clinical research you need these sorts of platforms. You need to know how to drive change, for example. I've just gone through that. You need to have really good quality partnership and stakeholders involvement, not project by project, at a system level. You need, in our case, to have good data and advanced analytics, health economics, clinical trial capability, evidence and guidelines, and a lot of digital tools. Without those platforms, we can't make a difference, and most of those people who are working there are not usually coming from healthcare or health research backgrounds, but they're absolutely invaluable. They're like the honeypot, and then people will grow around that. So for example, and this is just an example of that learning health system approach, everyone said you need to do consumer and community involvement. NHMRC, MRFF says you have to do consumer and community involvement. Any of you really know how to do consumer and community involvement? So great, I'll come and talk to you afterwards. So most of the time we don't necessarily know how to do it. And so we thought, well, there's no best practice, there's no really good research. How do we know how to do it if we don't know what we're doing? So we undertook research. We went out and did a lot of work on evidence from stakeholders, which included people in Adelaide, and what their needs and priorities were. We then went and got all the evidence from internationally and then generated some evidence where there were gaps from research. We then went and brought in evidence from practice, what are people actually doing, and then evidence from implementation. And we've implemented in the outer setting, which is policy, the inner setting, which is organisations and the individuals. And I think so what we will end up doing, this is MRFF funded research, is around the fact that there was national leadership and collaboration across the country. There was quite extensive research in the end, evidence synthesis. We were actually the ones commissioned by the NHMRC to do the national consultation on the NHMRC Consumer and Community Involvement Statement and the MRFF, and fed this research straight back into that policy context. We developed an organisational toolkit so that institutes and universities know what their role is and how they help. Because at the moment, people are not getting enough infrastructural support from their organisations. And then we will generate a national knowledge hub, which should be launched in about 2 months, which has the best evidence there is for all of the different stages across the research continuum on how you do consumer and community involvement. And there are so many resources on there because everybody just said do it, but people didn't know how. So whilst we've been benchtop or discovery researchers and then we've been doing clinical trials still, every time we get a problem that's sticky, we just use research to solve it and then bring evidence around that table. Another example, big data analytics. So for example, we want to look at a lot more work around risk prediction. We started with what is the problem we're trying to solve, how are we going to do this. We took all of the evidence from best practice guidelines and systematic reviews, identified the gap, advanced practice in the areas, including the methodological frameworks, looked at what we were actually doing in practice, and now we have about 8 risk prediction tools that are used nationally and internationally, especially in pregnancy. And we just keep going around on that circle around what is the next big problem, how are we actually going to do this in terms of best practice, with machine learning, artificial intelligence, and then human-computer interface design for the resources and tools that translate that information to the benchtop. So it wasn't just doing the artificial intelligence and developing the algorithm. It's also working out the hardest thing was working out how to get the machine learning algorithm into the back of a resource that actually could be used at the patient bedside. So it was about how we thought about it right from the start in terms of getting that out there. And this is part of our digital health ecosystem now. We have about 30 products that are used, many of them around the world, because that's often the outcome, one of the outcomes we end up with. In women's health economics, I want to acknowledge Emily Callender, who's probably going to make more impact in her career lifetime than I will, who's done spectacular work in pregnancy around patient-reported experience and outcomes measures, done a lot of work around highlighting gaps in diseases, looking at trends and burdens of disease, and we have a couple of papers that are in with Lancet at the moment, which are both important but also absolutely shocking in terms of the trends for adverse maternal and neonatal outcomes. And one of the things I think this sort of work will highlight is the critical need for more investment in research. We've been involved in guidelines both nationally and internationally, identified that practice is not following or addressing these problems, benchmarked a lot of practice and created a case for action. And then there's a whole range of strategies that are coming out around implementing change. And some of that implementation in change is a strong call or case for action that's coming out around a single pregnancy registry for the country. In fact, the title of the paper is something like Our Fractured Data System Trying to Fix It. And it actually is a research program around what a mess our national maternity data system is, because it is absolutely appalling. There are 15 different data custodians, they fight with each other, they have different definitions, they don't share their data because somehow they think it's not appropriate to share their data. It takes 4 to 5 years for researchers to get access to that data. When you get it, if the local politician doesn't like the message or there's about to be an election and you spent 5 years getting it, you've had government funding to research it, they can tell you you can't publish it because the whole system is conflicted. It's not independent, it's not transparent, the public has no access to it. And I won't get on my high horse, but it's clearly something we need to fix. In terms of our so that's some examples of how we approach the systems issues. In terms of just a quick touch on some of the research that we do, and we work in all of these areas. I'm a big fan of research centres of research excellence. That doesn't mean you go putting them in if you're not really ready to do them. I think many of these take a couple of years, but I've been fortunate to lead 3 of these, and they are really impactful. Polycystic ovary syndrome is just one of the areas we've worked in. It affects 1 in 8 women. We've done quite a bit of work on the causes, the endocrinology of the condition, Probably led a lot of the work around the clinical features from cardiometabolic, dermatological, reproductive and psychological features of what was traditionally thought of as a reproductive health condition, but is much broader. Our original Centre of Research Excellence in this took us from probably relative obscurity to now being the institution that is the leading institution in the world in this space, and 3 of our people are the top 10 out of 25,000 in the world, because we've been able to lead a body of strategic research in this. Many of the people involved in that CRE are from Adelaide and have made really valuable contributions. But we didn't just do the research. We did explore the experience and the burden and really emphasise the nature of the problem, delayed diagnosis, why this was important, highlighted the gaps, did a lot of primary research, which is translated in guidelines. Did probably the biggest body of work I've done in my career, which was around the evidence guidelines I'll talk about in a minute. Evaluated then what we're doing in practice, showed the big gaps, developed the first dedicated service in the country, and then looked at how we do that translation. And for example, in the last 12 months with the guideline that we lead here, which is not just a guideline, it's actually changed the way you do guidelines, we've reached directly 29,000 health professionals in presentations, and I'll give you a bit more of the stats in a minute. We've really influenced the way the condition is diagnosed. It's now called the International Guideline Diagnostic Criteria, and I won't go into this in detail, but it's made a big difference. The guidelines themselves have been a massive collaboration. So 71 countries, 40 societies, most of them funded the work. These are some of the publications that have come out of the guideline themselves. About 180 of our publications are in the guideline, influencing practice. But it's not just a guideline. The translation program has been very extensive. And again, we've worked with really good people who do the translation. So this is the recent impact analysis from the guideline. This is not the publications. The publications have been viewed over 1 million times and cited about 3,500. But of people who are actively viewing and using the resources platform, they're from 195 countries, even in the Vatican. We haven't worked that one out yet. But there are 780,000 people who have used these tools and resources. And actually, if I go back to my crisis of relevance in 2010, is my research making any difference? I'm seeing a person by a person by a person. I can go to sleep at night and go, well, 780,000 people have had resources that are really co-designed within each of their life, that make a difference, that they keep coming back to, and that are used all around the world and in multiple languages. Indeed, this body of work actually won the greatest impact of research award for Australia across all fields, not just healthcare, last year. And there's a lot more to that story. But it was because we started with the problem. We went through the research and then came back to the problem. And so this was some of the services that were set up, the government funded. The Victorian government has now funded another 20 services in this area, and the guidelines will drive that. It's Rob Norman's fault, but we've just finished working with the European Society of Human Reproduction Endocrinology. We were going to lead this work, but actually we went to them and said, there are particular reasons strategically why it would be good for you, because there's a different model of care in Europe, to lead this, and we will support you. And Rob and others from our Centre of Research Excellence were partners throughout this process and actually have been involved, and this has just been launched. Policymakers have been waiting for this. They're now looking at how they're going to influence practice based on that. The Ask Fertility app is now available and the resources around it. And on the weekend, we just launched the early menopause guideline. I should also say that when we've done this, the other thing is that there was not a single medication that was indicated or approved for use for polycystic ovary syndrome. And our research showed that about 1/3 of general practitioners, and that's broadly because we've got about 9,000 health professionals and about 5,000 consumers that we've got research on around the world, that they don't like prescribing things that are not specifically approved or indicated, even if they're evidence-based. So we've now got 17 countries who have approved the use of metformin for this condition. And if I'm hopeful that one of those in the next lot will be Australia. So we can start to see real impacts. We've also got evidence from what's happened with consumer knowledge about the condition, and that's about to be published, and it's quite dramatic over those years. So this sort of thing does make a difference. And I'll give you a final example. Have I got time? Yep. So this is just to give you an example of how randomly you can apply this approach to, if there's a problem, how do you research it? And it's not just about your approach to physiology. Is about 9 or 10 years ago, and it's be the last thing I would have thought I would have done. I was the only female on the program medical directors group, and there were 14 of us, in the largest health service in the country. And the board chair, and this is not normal, it doesn't happen to me, in fact I think so, only ever happened to me once. The board chair and the CEO rang me on a Saturday morning when I was at kids sport and said, Helena, we need you to do something for us. I'm going, me? Turns out that there was about to be a sexual harassment scandal that was going to hit the front page from male doctor and female doctor, and they wanted a spokesperson. I said, I don't know anything about sexual harassment. You just want me because I'm a woman. So I thought about it, and that time I did say no to the CEO, but I did say the reason you're ringing me is that I'm the only one there. So actually the problem is we need to change the culture and change the system so you have much more diversity. And that's actually an evidence-based strategy for addressing problems around sexual harassment and around equity and equality. So they said yes. I don't think they regretted it in the end. And it's the easiest thing I have ever got money for, because everyone wanted solutions, everyone wanted to take an evidence-based approach. No one was interested in emotive stuff. Most of my really great colleagues, male colleagues, just wanted to help but didn't know how and were scared to put they were painted into a corner with white paint in a room, and they didn't want to put their toe on the white paint, so they didn't say anything. But actually all of them really wanted to help, and if we took an evidence-based approach, they were usually the first at the table. So just like we took the same approach for those other things, we decided to take a research approach for this. This is actually already outdated. We now have a partnership centre for gender equality and leadership. Last thing I would have thought I was going to do. It's pretty clear the evidence shows it's not the individual male or the individual female that's the problem, it's the system. It doesn't matter whether you look at early career researchers, whether you look at women, whether you look at intersectionality. There's some really good evidence in other sectors about how you fix this. We now have 2 NHMRC partnership grants, publications in Lancet Series JAMA, New England Journal of Medicine. There's one coming up in Nature. I might get my Nature paper, which we would never have thought about, from really good quality research about how you address this problem. And DFAT has just funded us to take this program throughout Asia. So we do have a problem. Part of the problem is convincing people we have a problem. So this is actually Australia. Our women are the most educated in the world, officially. This is World Economic Forum data. Right now, that means it cost us an absolute fortune. So economically, women are disadvantaged from the time that they graduate, because many of our men are going into trades and they start earning money in their apprenticeship much earlier. Most people in this room have that similar disadvantage, but it is actually an economic disadvantage that's set up early. Then we have the most expensive childcare in the world and the highest minimum wage in the world, so it's almost impossible to have home help. If you're in many countries, you can actually have help at home, but it turns out, or you have government-funded support as you do in Scandinavia, but we actually have a bit of a unique problem, so that this, as soon as you've finished university, you then flatten out in terms of your hours worked. Many people say, well, that's because women want to stay at home and have children, and be the primary carer. That is not true. They actually would like to work about 1 day more a week than they can when they're parenting, and they would like to be able to co-parent, but we don't have policies about paternity leave. So it's just a nasty, wicked problem that needs to be fixed. That leads to this in terms of full-time employment, which leads to an absolutely massive problem when you get to superannuation. And I'm not going to present that data, but sometimes giving people statistics to show people we do not have equality and there is still a real problem is worthwhile. And in fact, I'm not going to make any political aspersions here. This was the LNP government, and this was Labor government. But essentially, we used to be 10th in the world on relative economic empowerment for men and women. We dropped down to 70th after Burundi under the last government. You can see there's been a dramatic upswing, and that's not necessarily this government, it's actually Teals, Greens and Labor who've had a positive quota system. So what you've now got is you've not just got women in influential positions, you've actually got them in positions that make a difference. And whilst most people won't recognise this, the policy environment for that's been quite impactful. So whilst I wouldn't have ever thought of myself as a crusader for this, it's actually been interesting because we've just been the researchers doing this. So we use this approach. What do we need to do? We need to stop looking at the individual, how we change organisations, because there's lots of evidence on how to do that, and how we change the policy and the systems. What is the evidence base and what process do we use? Exactly the same. We took evidence from stakeholders, evidence from research, which wasn't actually that prolific, so we've contributed to that a lot. Really interestingly, in terms of measurement, many of the governments are now putting in mandatory requirements for data, but that data collection is not evidence-based, and they're getting rubbish. So part of our approach was we came up with a National Data Gender Equity Framework. That was our data people who came up with it, and they're actually revolutionising with artificial intelligence and machine learning how that data is being analysed. And then we've done a lot of work on evidence for improvement impact. This is some of the approaches that we take, and this is what I call my Apple Watch. These are some of our initial partners, and you can see how far they are around the process of implementation and scale-up. The Australian Academy of Health and Medical Sciences has now taken this up as a major challenge, along with the other academies, and so has AMRI, and we're working with NHMRC and policymakers. So it's more about there's a problem, how do we use research to actually fix it? I remember having a discussion with the previous CEO of NHMRC, and I said, you know, time and time again, we pick individual leaders who've managed to survive and succeed, and we put them out front and they tell their life story. That's not evidence. That's not research, and that's not how we're going to change the practice. That's the people who've usually survived a system and succeeded. If you want to do this, why is it at NHMRC, which we're so beholden on using evidence-based processes for everything, but we're not going to use it to fix some of our most wicked, gnarly problems? I think that worked because we changed. I've also had the pleasure of working in a Women in Leadership program for about 10 years now. Turns out, Imperial does this too, the name behind the leadership program in terms of the university means you can charge more and more money, so it's usually 15, 20, 30,000 as soon as you put the word leadership in the title, and there is absolutely no justification for that whatsoever. But virtually none of them have been evaluated. So we've got a systematic review and a long-term evaluation coming out on this soon. But I must say this has been a lot of fun, and I've really enjoyed working on this. This program's now been for about 1,000 people in Australia in health and medical research and in healthcare, looking at how we can drive improvement and advance careers. And then very finally, and this is relevant to all of you, that was just one example of how we applied our research to something. Many of you remember the McKeon Review back in 2013, where they had a look at health and medical research. They spent 2 years. Many of us gave our blood, sweat and tears to this, said that most of the problems are we're all sitting in hamster wheels, we're all in our silos, we don't have solutions for a lot of this. And this was the primary message they came out with after 2 years. We all just need to work together. In fact, they didn't have the community in there. I took the liberty of adding that. Not how we're going to do it, but that we're going to do it. But they did come up with 2 recommendations. One was research translation centres, which are sort of a combined version of what they do in the UK in academic health science centres, academic health science networks, and what they call applied research centres. Put them all in one. And so we're going to have these centres that are going to get everyone to work together, and you have one here, which is a health translation essay. And they also came up with a medical research future fund. And whether you like it or not, and it was definitely pork-barreled for the first few years, it has very much changed the research landscape in Australia. So I had the fortune of working as the director of one of these centres at Monash Partners for about 8 years. Every time we got to a stuck position, didn't know what to do, we decided to go and do research. A lot of our research was actually in the UK, but we did research on how to fix the problems that we were dealing with and how to overcome the silos. The other thing we did is they originally accredited 4 of these centres, one in Adelaide, one at Monash and one at Melbourne. There's this little muddy river in our part of the world that somehow separates off 2 fantastic institutions, but anyway, and also one in Sydney. And they weren't planning at that time to accredit others, but we worked very closely with NHMRC to say, you can't tell me that you only want improved healthcare and research integration for people living in those places. You need to do this on a more national basis. When we did it, the first 4 ran away down their rabbit holes and started competing with each other. And the mandate of these centres is to improve healthcare. And there's absolutely no way we can justify that or being funded for that without translating. So talking about herding cats into a burning barn, we managed to get those first 4 centres to come together in a national alliance and actually collaborate. Then we managed to work with the others who were aspiring and to encourage NHMRC to fund them. When we got our first tranche of funding, we even gave some of the money voluntarily to the centres that needed to be accredited. And this was the centre that I had the joy of leading, and this is the more broader national landscape. But one of the things all the centres have done is tried to work a lot more on these platforms. And until very recently, the government had abysmally failed to fund them adequately. And so I'm sure many of you have stories that you either don't know what they are or they haven't done enough. But as of last week, the NHMRC has agreed that they will fund the centres, and the funding for those will come more freely. And they're going to be some of the vehicles that you can use to try and transcend this. So that's just a little bit of a journey. I haven't told you a lot about the nature of the research I do. As I said, we do a lot of stuff in mechanistic stuff. We do clinical trials, but as per my paper in MJ, I think it's this week, we have a much bigger responsibility to make those trials relevant for our population in terms of implementability. But we increasingly do more applied research. But it doesn't matter what the difficult problem is, you can apply research to fix it if your primary focus is on impact. And the last thing I will probably lead you with is that the community are the funders and the beneficiaries of healthcare in this country. And they're also the funders and beneficiaries of research. And they, alongside our frontline workforce and our health services, are the powerhouse behind our healthcare. But our research sits over here and our community sits over there. And it's really important that we actually work out how we all work together and are working on problems that matter and will make a difference. That's it.
Well, fantastic. Inspirational talk. Thank you so much. I think we have some MCRs and some volunteers. Yeah, fantastic. We're going to take around some roving mics.
This is your physics person in a data biology group.
Filling a crack. Thank you. Thanks. Does anyone have any questions for Helena to start off with? While people are contemplating, well, Sarah, you can just kick us off.
Helena, thank you so much. So compelling. I noticed that you invest in health economics and your centre has that as a pillar, and critically that's important in making the case for research. But how important is it to evaluate the impact of the implementation that you do, and particularly in relation to dealing with those pesky politicians who don't want to hear about the data? How do we demonstrate the benefit?
Yeah, no wrong door, as many ways as we unashamedly can. It's hard to do. For example, some of the evaluation of the guideline, reach is fine, but are we changing practice? So we've gone and evaluated whether it's changing prescription rates, whether it's changing testing rates. Some of it is, some of it's not, so we know where to target. Where we've made the biggest impact is in consumer knowledge, like massive increase in consumer knowledge of the condition. But the health economics is incredibly powerful. One of our programs around healthy interventions in pregnancy to prevent preeclampsia, gestational diabetes, adverse outcomes in pregnancy works. Just a systematic review in 117 trials. But in terms of getting it to practice, it was the health economics that made the difference. So the Victorian government is now implementing that across the state. And interesting, it wasn't just the health economics, the payer who it costs for those adverse outcomes is also the payer who's paying for it. Because the critical issue is that it's fine to say prevention, but it's a different political cycle and someone else who pays. But by demonstrating just that the same payer was going to get the same benefit, and then showing we could implement it in routine practice was really important. So the other thing, Sarah, is I often don't go to the policymakers. I had the privilege of working with Nicola Roxon. I don't know how many people in the room know her, but incredibly value-driven politician, previous health minister. There was something I was doing with a consumer group, and she actually said to me, "I'd really like to help you get this up." I said, "All right, tell me the formula." Chatham House rules. Anyway, she said, "Look, the biggest, put yourself in our shoes. Everyone comes and tells us this is the biggest problem. Everyone starts with, we need more money. Everyone starts with, poor me, my research is not funded. You're out the door before you even start. I need to know who you have at your table. Is everybody who's going to be the detractor here, or am I going to do something and someone's going to pull a rug out from underneath me? What is my risk in going to this space? I need to know that you've gone through a process, everyone agrees that these are the two biggest problems. This is a trade secret I'm giving you here. I need to know that this is the three most important things I need to do and why. And then I call it the refrigerator budget, but you need three budget options. The first budget option is so cheap you're not going to deliver anything, and you pretty much tell them that. The second option is what you actually want. The third option is when you go to buy your refrigerator, they have a $800 version, which is really crappy. Most of them are about $3,000. They have a $25,000 fridge that no one ever buys, but you feel justified buying a $3,000 one. So we would have three options, one of which was obscene, and pretty much they would go for the second one. It can take me 5 years to get to that one page, to get everybody on board, to get everybody agreed, to say this is what we need to do. But when I've done it, I've never not been funded, because that's what the politician need. And the other thing is our consumers take that, we don't. So the consumers go in without us, they tell the politicians what the problem is, we're just brought in as the solution. So they're not like that ladder of inference saying this is another PCOS person who's going to tell me that PCOS is the most important thing since sliced bread. But they want to listen and be responsive to their community, but they want evidence-based approaches. So you become part of the solution, not another one of their problems telling them to fund you. So I think that arguing for reproductive health investment is a bit of a no-brainer. especially with some of the data that's going to come out. Making that really compelling case is going to be really important, especially because our health system and your health system is cracking a bit at the moment. So how do we make the case that it's such a critical time of life? In my mind, that's not such a hard case to make. Does that answer your question?
Helena, the clinical academic is key to putting everyone together, and yet across the world they're becoming extinct.
Yes.
The hospital is very happy not to have them because they don't do enough work seeing patients. The university is very happy not to have them because they're not doing enough teaching. So what is the future of clinical academia? Is it something that is going to become extinct and therefore we've got to come up with different solutions? How do you approach it in your work?
Yeah, I think it's a really big problem, Rob. Although it is now recognised that clinician academics are critically important, even if they're a linchpin, they are critically important. Recognition's not enough and they need strategies. A lot of the research translation centres, for example, have come up with star research programs where they'll fund a clinician academic, but the mandate is you must work out how you're working cross-discovery, clinical and through into practice. But the biggest problem is our EFT for our clinicians to do any form of research and improvement, which in Australia is particularly poor. It's much better in Scotland, it's much better in areas of the UK, it's much better in Canada. It's not as good here. So there's been some fairly strong pushes, which I've been involved in, about advocating for use of MRFF funding, for example, for these sorts of roles or fellowships. But at the moment, the MRFF clinician fellowship stream on current estimations looking at who submitted and who was successful, the success rate's about 3%. So I told my team not to bother. By the way, if anyone wants a successful scheme, no one applied for the MRFF Industry Fellowship last time. So if you want to go for a fellowship where you're pretty much guaranteed of getting funding, Australia is appalling at engaging with industry. So there's a huge gap in that space. But in all honesty, Rob, it's a big problem that needs to be fixed. Everyone knows it needs to be fixed, and now I think people know it's more important, but I don't think we have the solution. And until it becomes a CEO's job to have research to be accredited, which is just starting now, and because just saying you get better healthcare if you have research integrated is not enough, it's not cutting the mustard. So until we start to get those sorts of policy metrics, public value of research and of clinical research, I don't know what the solution is. But one of the things we were looking at recently, we were speaking to the Friends of Parliament around research, was one of the points they made is every time you go to your local member, if you write your local member a letter, they will respond to you, not an email, a letter. They will respond to you. The more people who talk to them about a problem, the more they talk about the issue. Getting together, Friends of Parliament is actually quite influential, and Friends of Research in Parliament is also important. I think it's going to be a long journey. I don't have the solution, but I do know that it's now much more recognised than it was 5 years ago.
I might take one more question, or two more questions. Please, we'll start here.
Hey, thanks for such a fantastic talk. It was really inspiring. Do you think that the academic health science centres have helped with integration of the health system and the academic, the universities?
I think they could have done much more if they were appropriately funded. So they were originally supposed to be funded 10 million per centre per year. That was the recommendation from the McKean Review. They came out with a couple of years of 2 million and they got nothing, partly, I can say this way, it was largely government pork barrelling at the time. They are now going to be funded, but it'll take a while for them to get there. It's their job and they are very well set up for it. That's what they're supposed to do. The fortune I had of sitting around the table with the CEOs every month who cared for 16% of the country's population, the influence I was able to have in that space was really quite profound. And it was much more about finally stopping them from talking about research, because they are really intimidated by the word research, and actually telling you what their problems were and what innovation and improvement they needed. As soon as we got them to that, and as I was talking about recently, one of the problems for the academic health science centres, even if they're funded, and I actually said this to a very prominent group in the UK, a few years ago. I was offered a job to go and lead one, and unfortunately it didn't work out, but they offered me the job. But I did say to their interview panel, it included the Chancellor, the Vice-Chancellor, and quite a few people at a very prominent university. They asked me what my vision was for this organisation, which was the equivalent of one of these in the UK, a bit bigger. And I said to them at the time, can I speak frankly? They did actually reflect, you're Australian, so yes. And I said, if you want my vision, I'm not the right person for your job. Because what I can see is someone's built you a jetty and they built you a boat, the Academic Health Science Centre, and you're all standing on the jetty trying to work out how to break it up for firewood and who gets to take the most home. So I can't tell you what my vision is because you're still going to be doing that. But what I will do, which I didn't get the chance to do, is work out what the sweet spot is that absolutely all of you need. So you're all in the boat, rowing in the same direction. You actually have a vision to say this is what we're going to do. And it's not going to be one particular condition. It's going to be one of those platforms. Probably database, data-driven healthcare improvement or something. But you'll all be in that boat, rowing in the same direction with a vision. People will stop complaining about little things because they'll be part of something much bigger. You'll probably invest in the boat, and if I fall out, it won't matter because you're all going in the same direction. You don't want my vision. I think the thing about their research translation centres, I personally think they are a spectacular vehicle. And the people who step up and use them, and we've seen, in my centre, I've seen some amazing leaders who've done it, have really, really made a difference. They've got every emergency health department, ED director together in the middle of COVID and completely revolutionised what they were doing. They got all their antimicrobial resistance nurses who do infection risk, who normally are never involved in research, together with a whole lot of other academics doing viral studies in the university. They got people who were doing spectacular stuff in viral particle transmission and intubation in anaesthetic theatres together. So they're this spectacular opportunity for people to think just like I'm talking about. They're supposed to be a safe scaffolding. I think they're phenomenal. I just hope they get to live up to their promise.
Becky.
Thanks, David, for taking the question. I'll have a really short question, and it only requires a one-word answer. Thanks, Helena. Your talk was really, really energizing, and I love the way you spoke about looking at the questions and having impact and getting those answers and having really, really translational impact. And you spoke about, attacking the big questions. You talked a lot about politicians. You talked about Australian funding agencies. You talked about the community. And as a scientist, I guess I would like advice on where then do you focus on those big questions. You mentioned aging and obesity, but those are really Australian issues, and women's health is vast and different in different places. Yeah. Should we be focusing on the big women's health questions in Australia or globally?
The answer is going to be both, but your funders are Australian. And so one of the things, your funders might be international. We've got a Horizon grant. Don't ever get an EU Horizon grant. I've never seen so much bureaucracy in my life. But we got a very large Horizons grant and incredibly difficult to deliver. So you may be in a position over time where you do get those international grants. Some people get funding from NIH, etc., but most of your funding is Australian. So making a case about the area you're working. It doesn't mean, for example, that you don't work on an incredibly innovative, cutting-edge, new genetic agents in CF, which is going to have a global market. Really important cutting-edge research, but you need to make the case for why that particular condition. And that was just an example of the biggest problems. And the reason it was frustrating is because not a single person in that room was remotely interested in looking at the impact of obesity and ageing on the oversight, even though that was the biggest problem. We don't need everyone looking at it, but we need some people to look at it. So you've got to make your case compelling.
Yep.
Like, I
but
think
the global issues are big. And
they are big.
Are they being adequately funded
and in all
Australia?
fairness, advancing age and maternal obesity is not an Australian problem. It is an international problem. Developing countries, maternal obesity is rising much more than it is in Australia. Currently in the US, 50% of mothers who conceive are obese. In Australia, 20%, but over 50% are overweight. That impact on the whole trajectory is huge. So I'm just giving you that as a public health example. It doesn't mean don't work in other areas, but have a compelling reason why you're working in it. It wasn't one sentence, but there you go.
I think you can see that you've stimulated a lot of questions, a lot of thought. We're delighted that you took the time out of your schedule to come and talk to us. Please, everyone, could we thank Professor Teede for joining us for the 10th Lloyd Cox Memorial Lecture.